Wish you all a very good evening and welcome to the World Asthma Day webinar hosted by CIPLA. I am Dr. Sandeep Salvi, the Director of Pulmocare Research and Education Foundation based in the city of Pune. It is an extreme honor and a privilege to moderate this very important event on the occasion of the World Asthma Day. The first Tuesday of every May since 1993 is recognized as the World Asthma Day. This was initiated by the Global Initiative for Asthma in 1993, and since then, we have been recognizing the World Asthma Day for the last almost 33 years. This year, the World Asthma Day happened to be yesterday, that was the 5th of May 2026. And like every World Asthma Day, there is a new theme that drives the importance for that particular area for that year. So the theme for this year is access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. This clearly highlights that inhaled corticosteroids remain the backbone of asthma management. And despite this knowledge, not all asthmatics get inhaled corticosteroids. The Global Initiative for Asthma on the World Asthma Day released the Global Strategy for Asthma Management and Prevention. This is a document that has just been released today, and I would recommend all of you all to go to the website of Gina, www.gina.org, and there you will get access to this new global strategy report. There are also slides on Gina, what are the latest advancements that you could potentially go through, and if you would like to use them for presentations anywhere. The document, the Global Strategy for Asthma Management and Prevention, is prepared by a whole team of very eminent doctors, which include pediatricians, pulmonologists from all over the world. You can see the board of directors of the Global Initiative for Asthma on the left. And this year, Professor Guy Brussel has taken over as the chair of the board of directors. On the right-hand side, you can see the very eminent science committee that has actually gone through all the latest publications, filtering them off with a lot of hard work, with a lot of debate and discussion, and then choosing the ones that we should include in the GINA strategy report that will have major clinical implications. I have been very fortunate enough to have been a member of the science committee of GINA and have seen the rigor and the effort and the hard work that goes in firsthand. Uh, Professor Helen Reddell, she chairs the GINA Science Committee. She chairs it. She leads the science committee right from the front, and you will see the amount of effort that has gone in into the new 2026 GINA Scientific Strategy Report. So these are all the people who actually put in everything that goes into the Bible of asthma, the GINA Strategy Report. We are very fortunate to have Professor Helen Reddell, the chair of the GINA Science Committee, to tell us about what is the latest update in GINA 2026. Professor Reddell is the professor at the Sydney Medical School at the Woolcock Institute of Medical Research, and has a whole host of some amazing and fantastic achievements. To note, she has been awarded the Member of the Order of Australia in 2024 for a significant service to respiratory medicine and medical research. She will be telling us about what is new in GINA 2026. Following that, I have a wonderful panel of very eminent pulmonologists and pediatric pulmonologists from across the country. Dr. Sushant Meshram from Nagpur, Dr. Lance Pinto from Mumbai, Dr. Praveen Valsalan from Kochi, Dr. Saurabh Pahuja from Faridabad, and our own Dr. Barnali Bhattacharya from Pune. So after Professor Helen Reddell's talk, I will have the honor and the privilege to moderate the panel discussion, of course, along with Professor Helen Reddell. So without wasting much time, I would like to invite Professor Reddell to tell us all about the exciting new advances that have happened for the Gina 2026 update. Professor Reddell, all yours.
Thank you for that very kind introduction, and it's a privilege to be able to join you today. I'll just share my slides. Okay, can you see my slides?
Yes, yes.
Good, excellent. Thank you. So first, there's my statement of interest. So Gina itself is funded by the licensing of its report and other resources. It doesn't receive government funding or industry funding. Just a quick summary about the Gina strategy report. It's a global evidence-based strategy that can be adapted for local health systems and medicine availability. Our audience includes people from a very wide range of countries, and so it's important for you to have national guidelines that are appropriate for your medicine availability and local health systems. But Gina provides evidence that can be adapted for those circumstances. The report is updated every year. We do a twice yearly cumulative review that each time covers about the previous 18 months. And then we do a systematic evaluation of new evidence about asthma. So that's not just specific PICO questions, but evidence integrated across the whole asthma strategy. When we're looking at studies, we pay very careful attention to study design, populations, and clinical relevance. And the report undergoes extensive external review. This year, we sent it out to 70 reviewers. And the report, we try to have a practical focus, particularly with the figures. So not just what the recommendation is, but why and how. And as I mentioned, it's widely used. So the Gina strategy report is downloaded from over 200 countries, and it's available for free download from the Gina website through that QR code there. And I'll show that again at the end. So this slide gives a summary of the key changes in Gina 2026. There are many more changes than this, but these are some of the big areas. So diagnosis of asthma, some new assessment tools. In children 6 to 11 years, a new treatment option for mild asthma. In adults and adolescents, a new treatment option for mild asthma in Gina Track 2, an update on triple therapy in Step 5, and then for severe asthma, an update on new biologics and non-asthma indications, and on choosing between biologics. There's quite a bit about inhaler technique. And then probably the most important development this year has been intensive work to develop 4 new flow charts about acute asthma. So for adults, adolescents and children 6 to 11 years on one hand, and for children 5 years and younger on the other hand. And for each of those age groups, there's a flow chart for primary care and a flow chart for the emergency department. But I would encourage you, when you download the Gina report, to look at the beginning section on what's new in Gina 2026. So we have around about 4 pages summarising the changes in each of the areas, and they have direct links through to the section of the document that's relevant. So that'll make it easy for you to negotiate the report. So I want to start with diagnosis of asthma in adults, adolescents and children 6 to 11 years. So this figure has been simplified from last year. So the broad process is starting with talking to the patient. So are the symptoms, the history and then the physical examination typical of asthma? Because if they aren't, then you need to explore further for alternative diagnoses. It doesn't mean you have to do multiple tests, but you need to focus on whether there is a history or examination that suggests something else, because you should investigate for that. If the symptoms and history and examination are typical of asthma, and I'll show that again in a moment, then the next question is whether you have access to any form of lung function testing, so primarily spirometry or peak flow if that's not available, because the core second part of the diagnosis of asthma is demonstrating variable expiratory airflow. And so if those tests are negative, you might consider repeating when the patient has symptoms or consider additional tests, and there's a separate box about those tests. But if not, then that's when biomarkers can be helpful to support a diagnosis of type 2 asthma. But obviously elevated biomarkers can be elevated in other conditions. And in addition, low biomarkers do not rule out asthma. If you are not able to confirm variable expiratory airflow, then, and if other diagnoses are unlikely, then there's the option of empirical treatment with inhaled corticosteroid-containing treatment. But it's important then to review the response quite quickly between 1 and 3 months, including lung function if you do have it, to know, have the symptoms that you've been treating and lung function, if available, improved? Because if not, it's important to refer the patient for higher level advice. So the question, are the symptoms and history and examination typical of asthma? So that seems sort of obvious, but what we find is that in many countries, any patient who has wheezing and sometimes any patient with cough is assumed to have asthma. And so we have a problem with underdiagnosis on the one hand and overdiagnosis on the other. So these are the core features that make you think very strongly that a patient has asthma. If the symptoms vary over time and vary in intensity rather than just being constant all the time, if they're worse at night or on waking, if they're triggered by exercise, laughter, allergens and or cold air, if they occur or worsen with viral infections. And then the one that's absolutely classical of asthma is if the patient is running and they maybe get a bit breathless during running, but when they stop running, their symptoms get worse. That is very distinctive for asthma. There's virtually nothing else that can do that. If you have COPD or cardiac failure or vocal cord dysfunction or you're just unfit, then as soon as the patient stops running, their symptoms will start to improve. So this one isn't seen all that often, but when it occurs, it's very strongly suggestive of asthma. And then on the other hand, asthma is less likely if the main symptom is chronic sputum production or shortness of breath associated with dizziness, lightheadedness, or peripheral tingling. If the symptoms are associated with chest pain, if there is exercise-induced dyspnea with noisy inspiration or stridor, or if there's localized wheeze. And in countries with tuberculosis as high prevalence, that's an important one. So I want to move on now to asthma management, first in adults and adolescents. We repeat a figure like this every year because it is so important. Asthma management is not set and forget. We need this constant cycle of assessment, adjustment, and review of the response because asthma is a variable condition. So as I've mentioned, confirmation of the diagnosis may be necessary, but then we want to ask not just about symptoms control, but also about modifiable risk factors, and that includes low lung function, it includes biomarkers. We want to know if the patient has comorbidities that may contribute to either symptoms or exacerbations. We want to know about inhaler technique and adherence. And then it's important to ask about the patient or the parent and caregiver preferences and goals. Then treatment is not just about asthma medications, although those are critically important, but also treating modifiable risk factors and comorbidities and non-pharmacological strategies, and also education and skills training. And then when we review the response, we really want to know whether those factors we assessed in the beginning have changed, particularly symptoms and exacerbations, side effects, but also patient and parent or caregiver satisfaction, because if they're not happy with the treatment, then they're not likely to be taking it. So these are the most important changes in terms of the medications in Gina 2026. So in Gina Track 2, and I'll show the tracks in a moment, in Step 1 for patients with mild asthma, there's new evidence for anti-inflammatory reliever therapy, or AIR only, with as-needed combination ICS-SABA. Then in Gina Track 2, Steps 2 to 5, there's anti-inflammatory reliever with a combination ICS-SABA if it's available across all steps. In Gina Track 1, with inhaled corticosteroid formoterol combination, is still the preferred approach. And part of that is because of the depth and extent of the evidence supporting it, but also because, and supporting Gina Track 1 with ICS formoterol and the very substantial reduction in risk of severe exacerbations and oral steroid use, but also because Track 1 is a single medication, a single dose, and a single inhaler device across all of the steps. And so for both patients and clinicians, this is a very streamlined, simple approach that avoids problems with different inhaler devices and different doses. So a quick note about terminology, because we've seen a little bit of confusion in the literature. So anti-inflammatory relievers, so here you see as-needed low-dose ICS formoterol and as-needed low-dose ICS-SABA in Gina's Tracks 1 and 2. And then we call it AIR only, anti-inflammatory reliever only, with no maintenance treatment. So that's in these steps for mild asthma. As needed only ICS formoterol in Track 1, or ICS and SABA in Track 2. And that can be in separate inhalers if you don't have access to a combination. And then MART is maintenance and reliever therapy, which is only in Track 1. So you can only do this with ICS formoterol. And that's, as I said, one of the features that makes Gina Track 1 a preferred approach. So just to look at the treatment figure in a little bit more detail. So you see at the top, we always remind you about the things that are involved in asthma management. It's not just about these medications. So Gina Track 1, the preferred controller and reliever, reduces the risk of severe exacerbations compared with using a SABA reliever. But in addition, it's a simple single inhaler strategy. And then Gina Track 2, where we've got evidence for as needed low-dose ICS-SABA now across all treatment steps. But in much of the world, as needed SABA is the only reliever that is available. So in Gina Track 2, the change in Step 1 is that we now have evidence from the Batura study for as needed only ICS-SABA, particularly in adults, but also in some adolescents, published last year. The population in this study had poorly controlled asthma, and most of them were using a SABA alone, but some were on maintenance ICS or leukotriene receptor antagonist with an as-needed SABA. This study was fully decentralized, so it was done during COVID. So the patients didn't actually see the study staff, and because it was decentralized, there was no lung function monitoring. Patients were randomized either to this combination budesonide-salbutamol or to salbutamol, and each of those was taken 2 inhalations as needed in the 2 intervention groups. The primary outcome was significant, so a significant reduction in the proportion of patients who had a severe exacerbation. Now, these patients who had mild asthma, so the absolute risk of exacerbations was low, but it was almost halved. So the hazard ratio of 0.53 at a population level, since most people have mild asthma, this is a really important reduction in risk. Other outcomes, the annualized rate of severe exacerbations was reduced by almost half. There was no difference in quality of life, and as I said, lung function was not measured. So here's what the Gina Track 2 looks like. This is an example if you have access to low-dose ICS SABA. So step 1 is as needed low-dose ICS SABA, so air only. And then in steps 2, 3, and 4, the patient is taking maintenance treatment. We're familiar with this for many years, with a separate inhaler providing as needed low-dose ICS SABA. So it's important because in steps 2 to 4 you have 2 inhalers. It's really important that the patient understands the difference between their controller and reliever inhalers. And if they're in a different inhaler device, or if changing between steps it requires a change in device, it's important to train patients in the correct inhaler technique. But so from Batura here and from the Mandala study across 2, 3, and 4, we have evidence for a reduction in severe exacerbations with using ICS SABA as the reliever. And then, as I mentioned, so in much of the world, the only reliever available is an as-needed SABA. And so steps 2, 3, and 4 are similar to the ICS SABA steps, but here in step 1, we suggest that if you can prescribe an ICS inhaler to the patient, if they should at least take it whenever they take SABA, so that because we have small studies demonstrating that that reduces the risk of severe exacerbations compared with just using SABA alone. Once again, with 2 inhalers, you need to check that the patient can use both of them correctly and understands which they're meant to use for which purpose. Now, back to Gina Track 1, as I said, this is the preferred treatment option, and that's partly because of the magnitude of reduction in severe exacerbations, particularly in step 1, whereas there's a 2/3 reduction, but also the simplicity of this step up. 1 inhalation as needed, 1 in the morning and evening, or just in the morning, and 1 as needed, and then 2 in the morning and evening, and 1 as needed. So this is the example for budesonide formoterol 160 4.5, or beclomethasone formoterol 100/6 by either DPI or PMDI, and there's a box with other formulations. So this shows you the simplified version of this box now in Gina 2026. So you can see there's the step 1, air only. Now, the change this year is that we've reworded the information about the maximum doses. So what it in fact is not a limit on the absolute number of doses you can take in any day. But in fact, it's a level at which the patient should seek medical care. So for adolescents and adults, seek medical care if more than 12 inhalations of these formulations are needed in any day. And then for children, it's if more than 8 inhalations are needed in any day. It's really important that we convey we have a similar advice, even if the reliever is SABA. So we don't want to imply that the air-MART combinations are in any way more dangerous than SABA. They're safer. So that's why this wording has been changed. And then just a reminder about why we're not recommending treatment with inhaled short-acting beta agonists alone. So first, because people with apparently mild asthma who in the past were thought to not need inhaled steroids, we now know that they can have severe or fatal exacerbations. In addition, even an occasional course of oral corticosteroids increases the cumulative risk of quite serious adverse events, including osteoporosis, diabetes, cataract, heart failure, pneumonia, obesity, depression. There's a long list of these adverse effects. And just an occasional course, say once every second year, at a population level, you see this significant increase in adverse effects. In addition, using SABA regularly, so twice or 4 times a day, for as little as 1 to 2 weeks, is associated with increased airway hyperresponsiveness, but a reduced bronchodilator effect. So the patient is more likely to develop symptoms, but when they do, they get less benefit from SABA. And there's also increased allergic response, increased eosinophils, and so you can get a vicious cycle of increasing use. And SABA overuse, we know, is associated with a significantly increased risk of exacerbations and mortality. So use of 3 or more canisters in a year is associated with a doubling of a risk of severe exacerbations. But in addition to these factors, there's the psychological effect of starting treatment with SABA. It works so quickly and so well to relieve patients' symptoms that it trains them to regard it as their primary asthma treatment. And so if later on you start a prescription for inhaled corticosteroid, poor adherence with that is almost inevitable. So those are reasons why we wouldn't treat with SABA alone. But the most important reason is, in fact, this last one, because there's strong evidence for a more effective and a safer alternative, and that is anti-inflammatory reliever therapy, so as air only or MART. Now I want to move on now to severe asthma in adults and adolescents. So this is only about 5% of the asthma population. Key changes in Gina 2026 are around add-on LAMA, so the evidence has been updated, including an additional triple therapy in step 5 that was just last week approved by the FDA. So this one's budesonide, formoterol, glycopyrronium, and approved for age 12 years and up. So all of the other triples are approved at least by FDA and EMA for adults only. There's a biosimilar anti-IgE, omalizumab IGEC, and this has the same indications as omalizumab, so in many countries approved from 6 years and up for severe allergic asthma. There's also now depemokimab, a long-acting anti-IL-5, which is given by subcutaneous injection twice a year. And this is indicated for severe eosinophilic asthma and also for chronic rhinosinusitis with nasal polyposis for 18 years and up. And as initial therapy, there were similar outcomes as with mepolizumab, the anti-IL-5, including around a 50% reduction in severe exacerbations. We've also updated the information about choosing between biologic therapies, and I'll come back to that. So you may be aware that Gina has a decision tree about severe asthma. There are 4 pages in the decision tree, and I'm just showing today the third of those sections of the decision tree, which relates to choosing add-on biologic type 2 targeted treatments. So this is for people who have exacerbations or poor symptom control on high-dose ICS-LABA and who have evidence of type 2 inflammation. So I'll just show you this in a bit more detail. So when you're choosing between the available therapies, so the therapies that are available to you when you're prescribing, you need to first consider the local payer criteria, because these medications are so expensive that usually it's not possible for patients to afford them if they aren't subsidized by government or insurance. The second factor is predictors of response, and you can see these here on the right. I've expanded this section of the decision tree. So this has been updated since last year. So for omalizumab and the new biosimilar, just childhood onset asthma and allergen-driven symptoms. But for the other 3 categories of biologic therapies, higher blood eosinophils are a strong predictor particularly for anti-IL-5 and anti-IL-5R more exacerbations in the prior year, and adult onset of asthma. And then nasal polyposis is a predictor of response for each of these 3 categories, and higher FeNO for dupilumab and tezepelumab. So there's some updates there in terms of where you might be looking for the appropriate biologic for an individual patient. But in addition, the other criterion to think of is comorbidities that have a co-indication for biologic therapy. So if you have a choice between 2 biologics and the patient also, for example, has IgE-mediated food allergy, then that might be the biologic you would consider. And you can see that chronic rhinosinusitis with nasal polyposis appears in several of these, and EGPA with benralizumab and mepolizumab, for example. And then in addition to those non-asthma indications, when you're thinking about what to prescribe in biologic therapy, take into account the cost, the dosing frequency, the route, so reslizumab being intravenous and the rest being subcutaneous, and also patient preference. Now I want to move on now to acute asthma in adults, adolescents and children 6 to 11 years. So as I mentioned, this has been a major work for Gina, and we have 4 new flowcharts. So this one is for acute asthma in primary care for adults, adolescents and children 6 to 11 years. And then we also have a similar a flowchart that has a similar overall construction, but this time for the emergency department setting. And I don't think I've got a slide of it, but we have similar flowcharts for primary care and for the emergency department for children 5 years and younger. And that's involved a lot of work by our paediatric members. So just to briefly summarise some of the important issues for acute asthma in primary care for adults, adolescents and children 6 to 11 years. So one of the first questions is, are the symptoms typical of asthma? So we need to think about non-asthma causes, either instead of asthma or in addition to asthma. So for example, pneumothorax, anaphylaxis without asthma, inducible laryngeal obstruction, pneumonia, cardiac failure, and pulmonary embolism. And the differential diagnosis depends to some extent on the age of the patient. We want to know what treatment has already been given and the patient's response. If the patient has already taken a huge amount of short-acting beta agonist and had little response, you want to fast-track that patient through to higher level care. And we want to know if there are any red flag alerts in the history for risk of asthma death. So for example, if the patient has had multiple emergency department visits or unscheduled visits over the previous year, if they've had a recent hospitalisation, if they're not using any inhaled steroids, if they're overusing SABA, if they've got confirmed food allergy, and if they've got a history of intubation for asthma. So these are some of the things that raise your level of alertness for transferring the patient to higher level care or to a local emergency department. On examination, so we've recommended a standardised assessment with criteria for mild, moderate, severe and life-threatening, taking into account mainly respiratory rate, air entry, accessory muscle use, wheezing and oxygen saturation. And in children less than 18 years, we recommend using a validated clinical score, so for example PRAM, which I'll show in a moment, for assessment of severity of the acute asthma presentation. So this is just showing the way the flowchart works. So we've got an adult, adolescent or child 6 years or more presenting to primary care with an asthma exacerbation or acute asthma. There are those initial features that I suggested we should be thinking about. And then the categories of mild, moderate and severe or life-threatening presentation. So you can see that if it's severe or life-threatening, if the patient is unable to speak, drink or lie down, if their oxygen saturation is less than 92%, respiratory rate over 30, a silent or quiet chest, peak flow of less than 50% personal best or predicted if you are able to measure it, and then if they're less than 18 years old, a PRAM score of 8 to 12. So any of these features puts the patient into the category of severe or life-threatening, and it's acutely life-threatening if they're drowsy, confused or cyanosed. So then treatment is started. So for a mild presentation, we suggest 4 puffs of salbutamol by puffer and spacer, and C below refers to the bottom of the flowchart. But we also suggest using budesonide formoterol, 2 inhalations of the 164.5. If that's available, because there's plenty of evidence for using budesonide formoterol in an acute setting and, of course, in day-to-day management. You want to assess the response to that initial treatment and only if needed repeat once after 30 to 60 minutes. Whereas with a moderate presentation, you might want to give up to 3 times if needed, and add ipratropium if that's needed and available, and start oral corticosteroids. And it's essential that we review the response at 1 hour, or particularly in those with a moderate presentation, earlier than that. So assess the same sort of things that you assessed at the beginning. And if needed, give additional bronchodilator and assess the response. I don't know if you have this situation in India, but in Australia, what we find is there's this thing called burst therapy, where patients are given 12 puffs of salbutamol 3 times or 4 times in the first hour of treatment. There's no evidence supporting that, and significant increase in adverse effects for patients. Now, if it's a severe or life-threatening presentation, you want to arrange transfer immediately. If the patient has features of anaphylaxis as well, then it's important to give epinephrine first. So that can be intramuscular in any age group, or there's now also nasal epinephrine delivery devices that we wouldn't suggest in children, but in adults and adolescents. And then while you're waiting for transfer to occur, you need to give salbutamol, give ipratropium if it's available, give oxygen if it's available with a target of 92 to 95%, give systemic corticosteroids, and monitor the patient continuously until they're transferred. So I've mentioned if features of anaphylaxis, give epinephrine first. So in small children, we'd suggest only by intramuscular administration. So the suggested doses of SABA are somewhat lower than in the past, and that's based on a review of the literature. For salbutamol by puffer and spacer, the dose should be given as separate puffs by spacer, and usually by a tidal breathing technique if the patient is short of breath. It's critically important to shake the inhaler immediately before each actuation, and if this is a new inhaler, if you don't shake it before each actuation, you can deliver ultra-high doses of salbutamol. I've got a slide at the end about that. I mentioned reviewing the response and then thinking if the patient has already been given multiple doses of SABA, consider the potential for SABA toxicity, because lactic acidosis, which can occur from overuse of SABA, can lead to compensatory hyperventilation, which then can be interpreted as the asthma is getting worse, and so you get this vicious cycle of overtreatment. I've mentioned consider giving combination ICS formoterol for mild presentations. The onset of effect in acute asthma is as rapid as for short-acting beta agonist. And supplemental oxygen should be given only if saturation is less than 92% on room air. So for adults and adolescents, the target saturation should be 92 to 95%. And a reminder that oxygen saturation may be overestimated in people with dark skin color. You need to be very careful about that. And obviously, if your patients are at altitude above 1,500 to 2,000 meters, then the oxygen saturation is expected to be lower. So I think I've covered these features when I was looking at the flow chart. So one important thing is that an emergency department or primary care presentation, when the patient is short of breath, that's an absolutely important opportunity to document the diagnosis of asthma. So if you can do even peak flow before you give them some salbutamol, then you have the opportunity to confirm the diagnosis of asthma, write it in the medical notes, because that can save a lot of complications later on. And then we want to assess for discharge and arrange ICS-containing treatment, preferably MART with combination ICS formoterol, because that will significantly reduce the chance of another exacerbation occurring. And then be aware that even a single exacerbation that requires urgent or unscheduled healthcare or oral steroids is a red flag alert that the patient's asthma treatment should be reviewed to prevent another attack occurring. So that risk is higher if they've had multiple visits, but even one means that we need to do something different to reduce the chance of another one occurring. So here is the bottom part of the decision tree, so assessment for discharge. The things you want to think about arranging before discharge, starting or increasing their asthma therapy to reduce the risk of another attack. So don't leave it to the GP after the patient has gone home. Reliever should be taken as needed, not routinely. We need to train inhaler technique, continue oral steroids if they're started, and arrange follow-up. And there's a new box for more detailed discharge instructions. And then follow-up. So if this can only be done by telephone or via video, that's really important to take the opportunity to follow up, but face-to-face obviously makes it easier to assess the patient. So we want to know whether the exacerbation is resolving, confirm that the patient is using their prescribed inhalers. If they haven't been switched to MART, do it now. Confirm that they're not using their reliever routinely. Check and correct inhaler technique adherence. Think about their risk factors, their action plan, and if they've already had another course of oral corticosteroids, that's when we would suggest referring for expert advice, and then arrange the next follow-up visit. So, oh good, I've got it here. So these are the two flow charts for acute asthma in primary care for children 5 years and younger, and then acute asthma in the emergency department. So I'm not going to go through those in individual steps, but you can find those in the report itself. And the Gina slide set will be uploaded probably tomorrow or the next day, and we've got individual broken down slides about each of these flow charts. So just now, inhaler technique. I mentioned that this is important. So as you know, dry powder inhalers and pressurized metered dose inhalers are available. So dry powder inhalers are suitable for most patients from around age 4 to 6 and not older. But you need to check that inspiratory effort is inadequate, particularly in younger children or in frail older patients or patients who have very severely reduced lung function. So the key issues about technique are to load a dose, and that varies between every single dry powder inhaler. And the patient should breathe out away from the inhaler, take a strong breath in, and hold the breath for 5 seconds. Whereas for pressurized metered dose inhaler, the preferred normal method is a single breath and breath hold with or without a spacer. So breathe out first and then actuate the inhaler once and take a slow breath in and hold the breath for 5 seconds. So you can see that if patient is in different inhaler devices, that they have to remember a strong breath for a DPI and a slow breath for a pressurized metered dose inhaler. Now then, during a severe exacerbation or for young children, so 5 and under, or as I mentioned, so in some patients who are very elderly. So spacers sometimes have a face mask, but this should be used only if the patient can't use a mouthpiece. So for example, very young children and the elderly frail. And here with tidal breathing, you don't put multiple puffs into the spacer. You deliver 1 puff at a time with 5 or 6 breaths after each puff. And, you know, particularly for a young child, they're not going to be able to coordinate their breathing, and you just want to make sure that they've taken enough breaths to clear the spacer. But here, this critically important new recommendation, so it's been known for a long time that you need to shake the inhaler. But what I've discovered in talking to colleagues is that what is often done is if you're going to give, say, four actuations in a patient with acute asthma, that it's shaken at the beginning and not between every puff. So just to explain why this is so important. So some PMDIs are formulated as suspensions and some as solutions. Now for suspensions, they must be shaken immediately before each puff. And examples are salbutamol, fluticasone propionate salmeterol, and budesonide formoterol. So very commonly used inhalers, but they behave differently. So for salbutamol and for the fluticasone propionate salmeterol combination, a delay of up to 60 seconds after you've shaken it means that at the beginning of a new inhaler, the patient is getting up to 3 times the dose that you think you're giving them. And then as the inhaler is used up, they're only getting around 30% of the metered dose. So that's really important in the context of acute asthma when you're treating the patient in the emergency department or primary care. By contrast, budesonide formoterol is lighter than the propellant. And so if you delay after shaking, the patient is going to get a lower dose initially and a higher dose towards empty. Now, which of these occurs, whether it's going to increase the dose or decrease the dose, may vary between branded and generic formulations. And it's really hard to remember which is which of these, and which most clinicians don't know if a medication is a suspension or a solution. So our important recommendation is to avoid confusion. We should train staff and patients to shake every PMDI immediately before every puff. So it doesn't harm it if it's a solution, but it stops you having to remember which is which. So I think that's the end of my presentation, a reminder about the really important message of World Asthma Day this year. Access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. And the United Nations resolution that was passed last year includes the importance of making access to appropriate medications for everyone who has asthma. And then I just want to repeat that QR code so you can download the strategy report. As I said, the slide sets will be up within the next day or two. And there are podcasts with asthma experts on the website already. We will, within the next month or two, have a short guide and the severe asthma guide. So thank you very much for your attention. So I'll stop sharing now and we'll move on.
Thank you so much, Professor Reddle. There is so much of new knowledge that is introduced into the GINA 2026 strategy report. Just goes to show that there is so much of new knowledge that has been generated over the last 12 to 18 months. And to filter and to sieve through all these hundreds and thousands of papers that have been published, I think the scientific committee has done a tremendous job in choosing the ones that are relevant, are of good quality, and are relevant to clinical practice change. I would really like to acknowledge the hard work put in by the science committee and led by Professor Edel. And you have seen the output of this tremendous hard work. So many new changes this year in the GINA strategy 2026 strategy report. Uh, Many of them are going to change practice a lot. And to discuss this, what are the implications of what Professor Redl has just presented? What does it mean for the Indian population? What does it mean for doctors in India who treat asthma patients? What should they pick up? What is so very important and relevant from our Indian perspective? So we have this wonderful, eminent panel uh, comprising of Professor Sushant Meshram, Dr. Lancelot Pinto, Dr. Praveen Valsalan, Dr. Saurabh Pahuja, and Professor Dr. Barnali Bhattacharya. So let me start by asking Professor Barnali and Dr. Lance Pinto the first question. A pediatrician and an adult pulmonologist, which of the newer recommendations or revisions in the GINA guidelines, according to you, are very relevant considering the Indian scenario? Can you start with Dr. Barnali first? The ladies first? You're muted. Barnali, you're muted.
So that was a remarkable talk. And yesterday, the moment it was accessible to all of us, I like to read from the book. So I raced, I got my bound copy, spiral bound, and I've been, leafing through it, and it was still warm. So, what really I think is going to help us pediatricians is the acute exacerbation, how beautifully it's done the primary care as well as the ICU. And it's so clear cut, it's so beautiful for us that 6 to 11 and, in the under 5. And what was a wake up call, which a whole lot of us, including me, would have been making this mistake, which Professor Helen told us about the burst in Australia, which we do it across the country. Give it. Of course, we do shake and of course we wait, but we do carry on. And I read this, and yesterday I heard it in the podcast too, about the lactic acidosis and the hyperventilation, and feeling that the child is more breathless, so give some more. So that is a real learning that we have to percolate down. And the other problem in India is not just the SABA inhaler, there is so much of nebulization. So this can
Right.
do that much more harm because you're giving that much more dose. Just by buying a new inhaler and not shaking and giving, you're getting into 3 times. So what
Yeah.
would we be doing, So for me, that was a really important learning, which I'm going to start sharing with, the entire team.
Good. Thank
Thank you,
you.
Barnali. Lance.
So thanks for a great talk, Professor Riddle. And I think I went through the document as well. I didn't print it out, unfortunately. But some of the things I made a few notes. I think the emphasis on the inhaler technique is something that's really, really, really important, because it's not something that we think of. Just the variability in dose is not something that we intuitively think of. So I think this emphasizes the need to convey that to our patients. Maybe it also makes me more inclined to choose a DPI versus a PMDI because of consistency in the dose. It's good for the environment as well, I guess. So that's one more reason to possibly choose a DPI over a PMDI. I think AIR, or anti-inflammatory reliever therapy, is something that we have been practicing. So I'm glad there's more evidence with regards to the Batura study as well, which pushes us even at an earlier stage to think of anti-inflammatory reliever therapy as the default. From a research point of view, I think the use of the CAAT questionnaire is something that harmonizes things across COPD and asthma. So I think it makes it easier for us not to have two bunches of questionnaires and try to figure out whom to give which to. I think another interesting thing that I thought was made reasonably clear was the use of triple therapy versus a biologic, and how a biologic potentially could lower the rate of exacerbations than a triple therapy in the right patient. I think we'll discuss this a little more in detail during the discussion. But I think that's another thought process which needs to be stimulated a little more. While triple therapy is becoming default across the country for a lot of us physicians, I think we need to put a little more thought into that before prescribing patients with triple therapy. And I think from a cutting edge point of view, depemokimab is something that's exciting, which is twice a year. And the note on GLP-1 receptor antagonists is also interesting. It gives us one more reason as pulmonologists to start thinking of these drugs as being in our domain, sleep apnea being the other reason why these drugs are promising. So I think a lot of exciting stuff, a little bit for everyone is what I would think.
Thank you,
Uh,
Lance. Helen, you want to
Cindy, could I
say
just
something
make
else?
a quick
Yes,
comment
absolutely.
about inhaler devices? So the advice we got from the pediatricians was that in the young children, that nebulizer is not preferred because it takes longer and the children are more distressed. So that's something that I certainly wasn't aware of. With DPIs, so the evidence for DPIs in acute asthma goes down to about FEV1 of about 30% predicted. I mean, obviously technique is important, but it's often not thought of in the context of acute asthma, but there's plenty of evidence about it. Thank you.
Yeah, thank you, Helen. If I would like to continue with Helen, you and Dr. Sushant Meshram. Perhaps, Helen, you could give us what is the current state in Australia, and Dr. Sushant could tell us about India.
Right.
Despite
So
the
in Australia, there's very, very little use of anti-inflammatory reliever therapy. Australia is sort of a bastion of short-acting beta agonist reliance. A large part of the problem is that salbutamol is available over the counter in Australia without a prescription, and our Australian guidelines did not change to recommending AIR or MART as the preferred option until 6 months ago. So we have Australian guidelines, and there was this long lag between when Gina's recommendation changed and when the Australian guidelines changed. So we've just embarked on a large program to try and raise awareness of the importance of using anti-inflammatory reliever therapy, but there's really very little knowledge in the community and in the emergency department that there's any alternative to using the familiar blue puffer for relief of symptoms. Interestingly, just today I saw a paper from the UK which showed a really substantial shift in use of ICS formoterol as sole treatment compared with SABA as sole treatment. So there's a country that the UK had its guidelines change in 2024, and they've really strongly promoted the new guidelines, and they have seen quite a substantial change at a population level. So in Australia, we've got a way to go because emergency departments reinforce short-acting beta-agonist use and oral steroids as the main treatment for asthma.
Yeah, Dr. Mishran, despite the availability of anti-inflammatory inhalers, we have AIR, we have MART at affordable prices. What is it that is preventing the physicians for writing inhaled medication for asthma management?
Yeah, at the outset, I would like to thank Dr. Helen for a wonderful presentation and what she has told right now. Same situation do exist in our India also. The lacuna of not using it, mostly what I find that the pulmonologists or chest specialists, those who are there, they are using as per the guidelines, but most of the patients, asthma patients, they are being treated by the general practitioner or physicians. So the concept is that asthma is a episodic bronchospasm, so they don't consider it as it's a chronic inflammatory disease. This concept is yet to be there in the physicians and general practitioner. So unless we are going to teach them or tell regarding the guidelines of use of anti-inflammatory agents, and asthma is not just a bronchospasm, it's a chronic inflammatory disorders. So that is one thing that we need to educate. Another thing is that even patients, they themselves feel, as in one of the slides, Dr. Helen also mentioned that the patient feel it's a quick reliever. So that becomes one more important factor, that taking the inhaler salbutamol or short acting alone. And another thing would be cost. Cost could be one factor that has to be considered, because if the patient feels that with the same low cost he is getting relief of the symptoms, why need to go further? That could be another reason. But most prominent reason is that it is lack of awareness among the physicians as well as in the community of patients. That is the main reason.
Thank you. Thank you so much. Dr. Barnali, this is for you. Asthma often begins early in life, yet many children remain undiagnosed and therefore undertreated. How can early access to anti-inflammatory inhalers alter the disease trajectory into adulthood?
Sandeep, as Dr. Meshram said, it is not access to anti-inflammatory that's a problem. It's not so very expensive in our country. It's just that because it's not diagnosed, or because it is diagnosed but is not communicated and goes with the name of, seasonal cough or allergic cough, and they are not treated. Because if the doctor is not confident enough to label it and treat it, that is how it is missed. It is not got anything to the access. It's available even in villages, but the doctor needs to be prescribing. So they keep giving SABA or home nabs with SABA, and therein lies the problem, not realizing that they are remodeling airways, they're interfering with lung growth, and a lot of adult asthmatics or COPD is what the pediatricians have contributed by not managing on time. So the onus truly is on us, and we need to pull up our socks. And when we say India contributes to 42% of global mortality, and most of them are adults, it's us who actually taken it to that level. So it's the onus hugely lies with us. So it's not accessibility, it's not applying the knowledge that we have.
Yeah, I think that's such an important message, Dr. Barnali. I'm sure a lot of primary care physicians would be listening to this. And a key message is please do not deny an inhaled corticosteroid to your asthma patients. Be them children, be it children or be it adults. I think that's the most important message today. Uh, Dr. Praveen and Dr. Pahuja, some very important question for you. Given that primary care is a first point of contact for most patients with asthma, what practical steps would you suggest so that we pick them at an earlier stage? Do you think there would be a role for newer AI-enabled screening tools that could help in picking up these cases earlier? Yeah, Dr. Praveen first.
Yeah. Hi. Thank you for me being here, and excellent talk and very informative talk from Dr. Professor Redel. Thank you once again. So, as we all know, primary care physicians, they are the first point of contact in most of the cases. I mean, even when we talk of, we have so many tertiary care hospitals where there is a lot of access to it, but still in India, even it's the primary care physicians who are the first point of contact. And in fact, there's a huge need, as others have already pointed out, there's a huge need to pick up these, so sort of an active case finding to find out who has asthma and who are at risk for future exacerbation, to prevent a recurrent exacerbation admission, and also to prevent this fixed obstruction that can happen in this. So we need to have an active lookout for it, and we need to look for an active case finding, probably a proactive screening by looking at who has this recurrent symptoms, who has a recurrent chest symptoms, who has an associated allergic symptoms like an recurrent allergic rhinitis, which becomes which goes into the chest, who has some other atopic histories, and also to look for the triggers which is triggering these patients. So these are probably the way that we can look for an active case finding, and also the things like, say, for example, an occupational related asthma. So these are all probably, we need to have an active lookout for it. Serial peak, when we have this, of course, serial peak for monitoring or and PFTs do help, at least to look out, to have and to see this diurnal variability which we have already mentioned. The role of AI, yes, especially especially we have a huge data of our electronic health records. If we have an AI and if they can actually sieve through because we as a physician, we may not have time and we may not have this. We may not have that ability to go through this humongous task of sieving through the whole thing. So AI is something that can probably do it much more faster, and to find out those patients who has a higher chance of developing this fixed obstruction or recurrent exacerbations. So that's something that probably an AI can easily do. Similarly, these smart inhalers, digital inhalers, these are all part of those evolving AI systems, probably helping out to, and the newer AI probably diagnostic systems, which is coming to differentiate between asthma and other causes of breathlessness, etc., etc. I'm sure these are going to be coming in the near future.
Thank you so much, Dr. Praveen. Dr. Saurabh, your thoughts?
First of all, I would like to thank everyone, and I'm honored to be a part of this panel. I think so. I'm the youngest one here. So having the lowest most experience as far as you guys are considered, and really enlightened to listen to Helen ma'am. And I think so after her talk, I don't think so we need to go through in detail in Gina 2026, because all the changes have been absolutely fantastically told by ma'am. So coming to the question, Professor, I think so primary care physician, as Varnali ma'am also said, this concept of seasonal worsening, seasonal cough, I think so they should be educated first. In our country, we all know that the primary care contact givers are the people who are working in rural areas, who just not have that access to these guidelines which we are following as a pulmonologist in tertiary care centers. So making them available these documents which are there, so that they can actually identify a patient who fits into this category of asthma, recurrently training them. Like if you see our tuberculosis program in our country, how government has made it mandatory that we have to follow a particular guideline. And now what we have done in the last few years is active case screening is being done. We are picking up cases, we are notifying cases, and everybody is being treated in a structured format. Similarly, pushing our primary care physicians also to follow these guidelines. Not that extensive they can go through, but at least few basic slides made for everybody which they can go through so that they can pick up these patients early. We all know that when a patient like a suspected asthma comes, these primary care physicians, they all have a habit of giving them an anti-allergic, a cough syrup, maybe not even considering a nebulized medicines or maybe considering an inhaled therapy for them. So highlighting these patients that if this patient come back again, maybe in another season or maybe just after 1 or 2 months, highlighting these patients on their prescription, making some kind of a note that if this patient come back again, there is a possibility that he might not be just suffering from a plain viral infection. It can be an asthma actually, which is frequently getting triggered. So that can be a step which can help these patients. Coming to the AI part, yes, AI is absolutely a wonderful tool, not just for the records which we have, even if we have some kind of AI tools which can be circulated in the community, where a patient can just go and put his symptoms that I have these symptoms, with change of season, I have these symptoms, these are my triggers. And then that AI tool telling that patient, okay, there is a possibility you might be suffering from asthma and you should be worked up properly by a physician or by a pulmonologist who is expert in dealing this. We all know if we tell the patient that he has an asthma, he's not gonna agree. 80% of our patients are gonna say this doctor is not a good doctor because he has labeled you asthma. He's gonna change the doctor as far as our country practice is considered. But if it comes via a tool which has been there on their mobile phone, I think so acceptability for that tool is gonna be better than a doctor telling them that you are suffering most likely from asthma.
Very interesting. Professor Redl, do you think that the subsequent Gina reports, strategy reports, will have a section on artificial intelligence in asthma diagnosis and management?
Yeah, so we've looked at quite a lot of articles about this over the last 12 months. And so at the moment, there are quite a few sort of proof of concept studies, but they're mostly tailored to a specific health system or a specific population. So we just have a small section on, essentially digital technology in asthma management. We've sort of got an active watching brief to see what emerges as, sort of coherent threads. I think the potential for AI is really important. We've got to think about how to avoid over and under diagnosis. And this is where the value of listening to the patient is so important, but that can be captured by AI. For example, if the patient reports shortness of breath or wheezing and they're pointing to their throat when they're talking about their symptoms, straight away, and particularly if they're saying, symptoms are triggered by strong smells or pollution, that you're thinking straight away that this is more likely to be a laryngeal problem, inducible laryngeal obstruction than asthma. So there are that, and the one I mentioned about symptoms getting worse after you stop exercising. Those two and features like those could contribute to an AI tool to make it much more specific for asthma. So, yeah, watch this space, but we haven't found anything we could make strong recommendations about yet.
Okay, thank you. Lance, we all know that asthma is essentially a clinical diagnosis, but many a times we do need objective evidence to support it. The uptake of spirometry is growing in India, but still quite suboptimal. There are reports of use of other biomarkers like pheno and oscillometry, which are now upcoming in India. What do you think should be the role of these in clinical practice, and how do you interpret their role along with your clinical judgment?
So I think we use pheno reasonably extensively at our center, sir. And I think even the document makes it quite clear as to where to position pheno. So if a person has a history which fits in with asthma, you're reasonably convinced clinically that the person has asthma and yet has a normal spirometry, your stethoscope doesn't pick up a wheeze, I think biomarkers are useful in giving you some sort of an indicator. A lot of our patients have a CBC done very often in the past year or so. So looking at peripheral eosinophils is useful. So I think pheno serves this kind of a triage purpose. I think the document is very clear about the fact that it's a rule-in test. It should not be looked at as a rule-out test. So a normal pheno shouldn't reassure you completely that this is not asthma. But if a pheno is elevated, I think it has a certain role in this context. It also has a role in kind of giving us an idea of what the inflammation within looks like. So if a person is on moderate to high dose ICS and the pheno is still very high, I think the first step would be to reassess inhaler technique to make sure adherence is in place, to revisit that, not just assume that it's inflammation. But if all those checks are in place and the pheno is still high, then some of the newer biologics, for example, like dupilumab, are indicated in the grid of the next step when it comes to escalation. So I think these are some of the reasons. I mean, there are caveats to this. So pheno tends to be lower in smokers, tends to be decreased in people who are obese. There is a diurnal variation in the pheno, which is actually just the opposite of what it is in eosinophils. So I think all of these things need to be taken into consideration. But it's a useful add-on tool for a small subset of patients who, despite having everything that fits into asthma, still don't necessarily give you the tests. And if you don't have bronchoprovocation, which I think most of us in India don't have access to. Oscillometry, I think the document suggests oscillometry is a possible tool in children. Not it doesn't mention use in adults. I know a lot of people in India use oscillometry, and I think, again, at a tertiary center, when I have access to lung volumes, when I have access to spirometry, it's very rare that I've got additional value out of an oscillometry. Again, we use it sometimes in pre-CABG patients, for example, when they have tight triple vessel disease, and the surgeon doesn't want us asking the patient to do a forced maneuver. We would use it in certain specific circumstances, but as a broad rule, I don't tend to use oscillometry much.
Okay, great. Thank you. Dr. Praveen, this is for you, and perhaps Helen could also add to this. The SAD phenotype of asthma is getting increasing recognition, the small airways dysfunction related asthma. How important do you think it is that we should identify this phenotype? And is there a specific treatment that we have, or does the Gina document give us some direction as to how do we manage these patients of SAD asthma?
Yeah. So small airway disease is something that we tend to overlook, and I think it's something that is pretty common in a huge chunk of asthmatics actually. Probably it's probably more commoner than what we actually see, but because we don't have many indices to actually look at the small airway. Of course, there are things like the FEF 2575 or the forced oscillometric technique to find out the small airway disease, but that's not available everywhere. So, but then when it comes to the small airway disease, the importance is that it is a major determinant of, if it's not identified, it could be a major determinant of a poor asthma control as well as recurrent exacerbation and a high degree of the disease severity. So that's the need to recognize an SAD phenotype.
Okay.
The problem with the SAD is that the traditional spirometry, what we talk of the classical FE1, FEC, will not be able to identify the small airway part. So that's where we need to rely on those small airway values so that's basically a sort of an silent zone. And the other aspect is regarding the therapeutic part of it, that the larger sized particles may not actually reach that small airways, and that so if we tend to give that larger particles content, we think that okay, this could be a difficult to treat asthma rather than it's a small airway disease which need to be tackled altogether, sometimes separately. So that's a need for watch out for the small airway disease. The clues that actually can give that whether this could be a small airway disease in these patients is, one is, even after treating with a routine inhalers and the patient is not improving, then think of a small airway disease as one of the causes. Patients who are obese, who has some significant nocturnal symptoms, they all likely to have exercise-induced bronchitis. They all likely to have a small airway disease, and if we have a normal spirometry, then probably the significant scooped out curve with the normal height of the expiratory curve suggests that this could be a small airway disease.
Okay.
And of course, the other things like poor response to this large particle inhaled corticosteroids, SABA, etc.
Okay.
The thing is, we don't. So we need to, because FOT is. I am sure, I know that impulse oscillometry, which few people in India they do to look out for the small airway disease, is probably some more sensitive indicator. But FOT is not available in many parts of our country, partly to do with the cost too. So in those aspects, we need to look.
Yes.
We need to take into consideration all these points together. That looking at the history, whether the
Sure.
patient is actually not responding, the PFT part, and then we come to a conclusion that okay, it could be a small airway disease.
Sure.
And
Uh,
therapeutic treatment part, Gina also talks about the the ultra fine particles and etc. to treat that small airway disease, which can actually reach the lower airway.
Yeah. Okay. So Helen, the GINA document tends to underrepresent the sad phenotype of asthma. Is it because we don't have an extra fine formulation of medications available, or there are no clinical trials that tend to show us the evidence?
Yes, yeah, it's the latter. So the evidence about the prevalence of small airways disease is important, but it is actually primarily a theoretical issue, because what we're lacking is clear evidence that using a smaller particle formulation actually changes outcomes. So there's surprisingly little evidence. I think there was one systematic review from one pharmaceutical company where they had compared fine and non-fine particle size of the same product. So that's useful to know. They didn't find any difference in those results. But across the spectrum of asthma medications, there really are very few studies in which the same medication has been delivered by large particle and fine particle. So there have been some studies looking at adding fine particle inhaler on top of existing therapy, but unless you compare that with the same change with the patient's previous inhaler, then you can't say whether it's made a difference or not. So it's the lack of clinical trials the lack of clinical relevance that is actually important if we had evidence that using fine particle changed outcomes, then absolutely there would be a lot more about it. So there's an evidence gap there that I think needs to be filled. And it needs to be filled really by pharma companies, because clinicians mostly don't have access to fine and non-fine particle in the same molecule.
Okay, great. Pranali, this is for you. Cough variant asthma in children. We see a lot of it. How confident are you that giving them anti-inflammatory medication would actually help? And what do you do in your practice to these children who have cough variant asthma?
So first I have to know that the cough is cough variant asthma. So therein comes a detailed history as to, when asthma, cough is a very important symptom, as Professor Helen also mentioned. So I'll have to go into the variability, whether it's dry cough, when is it diurnal variation. And she told us this wonderful thing that cough while running and which increases post running. So all those detailed history is taken, and we also have a significant chunk of kids who may be habit coughing, just which is dysfunctional coughing. So you can make those kids out, like they come in coughing, 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 and when you're talking to them, they're so intensely looking at you that they forget to cough. And then again, when you look at them, say, so how are you today? They again start coughing. And then the parents tell you, well, when he's watching television or he's with friends, he doesn't cough. But when it's meal time or study time, he begins to cough and he sleeps so well at night. So I know that this is not cough variant asthma.
Good.
But this only happens after ruling that out. If this is a child more than 5 years, I would definitely want to do a spirometry. And in a lot of those habit corps, we say brilliant results. And, they are just so happy with the reports. And I would get them to do a diurnal monitoring of their peak flow for 2 weeks to see as to how it's happening. But when I am pretty sure with the history about the variability, it's frequent, it's variable, then I would definitely give them a trial of inhaled corticosteroids, and I would document all this. What I loved, what Professor Riddell mentioned about documenting. So I would document it, because in case they would choose to take a second opinion, the other doctor will go by what I have thought of, instead of saying, oh, no, 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 and rubbish it. So I would document that this is how the child came, and this is what I am thinking, and this is why I think this child will benefit by a trial of inhaled corticosteroids, at least for 6 weeks, I would give. And so when I start, I'm confident because I have given them enough time. So this is what, when we say using AI because it saves time, a bit of me says that when we do asthma practice, we need to invest time, because therein we are also forging the bond. So I would be confident when I am confident that it is covariant asthma and nothing else.
Great. Thank you so much. There's a quick question from the audience, Dr. Arijit Datta from West Bengal. If anybody would like to answer this, please explain me how to differentiate between inducible laryngeal obstruction and asthma. Praveen, you would like to do that?
Yeah. So inducible laryngeal obstruction, previously we used to call as this vocal cord dysfunction. So the primary difference is, one is that it's between asthma and theoretically, one is that it's at the level of the throat, and the other is at the level of the lungs. And in the throat, it's usually happens with some sort of stress, like whether it is strong smell, some sort of emotions, laughing, crying, or whatever it is. These are the causes that can triggers it. It comes and it goes off suddenly. And in these patients, they find it difficult to breathe in. That is sort of a stridor. Whereas in asthma, it's the other way around. They find it difficult to breathe out, and it's triggered by inflammation. So to diagnose it, we probably will have to do an nasal endoscopy for an inducible laryngeal obstruction. Whereas for an asthma, it's primarily the pulmonary function test. And these patients will not, inducible laryngeal obstruction patients will not improve with inhaled corticosteroids, whereas asthma, the cornerstone is anti-inflammatory therapy.
Okay, good.
Can I just add quickly to that?
Yes, please.
That was a brilliant thing that you said, Dr. Praveen, is that it's also going back to what Professor Helen told us, that in induced vocal laryngeal obstruction, if they are running, the breathlessness would be immediately then, and with rest will go away. Whereas in asthma, it comes in later. So that's very important. And there is no response to SABA in them. In fact, it can make it worse. So those are two very important things.
Thank you so much.
Thanks.
If I can have quick answers, because I just have a few more questions and it's already past time. For Dr. Pahuja and Dr. Sushant, Gina introduced a major paradigm shift in 2019 by moving away from SABA only as the treatment for asthma. Now it's been 5 years, more than 5 years. How do you perceive this change in whether this change has got translated into real world clinical practice, or do you still see a lot of use of SABA only in the management of asthma? So Dr. Meshram and then Dr. Pahuja.
In fact, in tertiary care and the specialist practice, right, pulmonologist, chest physicians, they are definitely prescribing as per the guidelines. There is definitely change, and in our teaching institutes also, as we follow the guidelines and we teach our students also, there is definitely change. But when we see that the patients are referred to us, from peripheries and all, so there we see the prescriptions sold of salbutamol. So still in periphery or at the suburban areas, the patients which are being managed by primary care physicians. And see, in India, we are having patients being managed by the different pathies also. Fine. So at that level, definitely the translation of this Gina has not been there. So we need to, again, as initially also I told, that we need to educate. There should be a lot of this what can I say, educational activities and conferences regarding this, teaching the primary care physicians.
Absolutely important. I think education, education, education.
Yes.
Thank you so much. Uh, Dr. Pahuja, and then maybe Barnali, any thoughts on this as well?
I think after Dr.
Yes,
Pahuja.
Dr. Pahuja, yeah.
Definitely, sir. I would say there has been a change, as sir rightly said, in tier 2, tier 3, or big cities. You will see definitely people are more using track 1. I don't know where they got the concept of track to the peripheral people. So, whenever a patient comes to us in a setup, he is going to be using a SABA SAMA nebulizer along with an ICS. They are not aware that this is actually track 2 of GINA, where you have to use always an ICS with the SABA. But somehow that practice is being percolated to the lower level physicians as well as to the people who are practicing in the periphery. Somehow only very few people now we see are only on salbutamol. If that person has not never visited a physician or never visited a healthcare practitioner, he might be still using a blue inhaler. But majority who are visiting, even a pediatrician, even a physician, or even a pulmonologist, or even a peripheral healthcare setup, they are being prescribed ICS along with SABA and SAMA, although they don't know that this is a part of GINA as a part of track 2.
Excellent, excellent. Yes, Barnali, your thoughts on this?
This 2019 and COVID came in 2020. So in pediatrics, unlike adult, pulmonologists dealing with asthma, you only do one dose, but we also have 6 to 11 and under 5. So those under 5s are allowed SABA, that their relievers are SABA, unless and until we have a revision, as Professor Riddell said, after 3-4 months. But even the current one is that you can give SABA as and when needed, even when you've stopped discontinued treatment. So there were children who were maybe 4 years, and came COVID, and in COVID we saw hardly we were seeing any asthma, because they were not exposed to viral infection in school, they were not exposed to pollution, they were at home and they were getting healthier food because there was less of junk, and moms were at home, and so all those factors went into no asthma. And then the same lot of kids whom we had also forgotten about, suddenly I started seeing significant amount of kids coming in mild to moderate flare up in the clinic, and they were obviously taking the blue inhaler, because 3 years back I had told them that you can use the blue inhaler if your child has problem. And here now it is me who's wanting to whack myself because I brought them to that level. So I saw real life that how true it was that just SABA alone can make your mild exacerbation into life threatening. So that's why we kind of have taken it on a war footing, that cut down on your SABA. And today I've learned even much more about how even that SABA that you use in the flare up, you need to be very, very mindful. So
Such an important message, Barnali. Thank you so much. I think in the interest of time, we will need to shut down soon. But before we leave, I would like to ask each one of you, what is the important carry home message that you would like to convey to the audience? I will ask Helen last. What did she learn from the points that she heard from the Indian doctors? Perhaps maybe she's got some advice for us as well. So maybe Dr. Sushant Meshram, we can start with you, then Dr. Praveen, Dr. Pahuja, Dr. Pinto, and then Dr. Barnali and Dr. Redel. Yes, Dr. Meshram.
Yeah. So we should spread the message that salbutamol is not a first line treatment for the asthma. It's an anti-inflammatory agent, like ICS has to be used.
Very important. I think that's an important message. Absolutely. Thank you. Yes, Dr. Praveen. You're muted. You're muted.
So probably that we should have a proactive screening to find out who are asthmatic, and I think it's more so among the children. I think Professor Barnali might agree to that. In adults, probably we might tend to, treat them a little bit earlier than in the children, and also to look at the risk factors which can, later on lead to the fixed obstruction and the recurrent exacerbation and the difficult part of the treating the asthma.
Very good, very good. Thank you. Dr. Pahuja?
Sir, I think so. If we follow Gina religiously, majority of our patients are going to be cured. That is, I think so, the message. But if still you have patients, now there are a lot of things which have come up. As ma'am has told, the 6-month therapy has also come out as a part of biological. So we should be now treating our asthma patients as a rheumatologist treat their autoimmune disease patient proactively and targeting maybe a remission in these patients rather than just telling them that this is a disease which is going to be there with you for entire life and you should be taking off and on these inhalers. We should be proactively telling them, okay, if we control the inflammation early go, maybe we can achieve a condition of remission, as our rheumatology colleagues are always talking to the patients.
Very good, very good. Thank you so much. Lance?
So I think from a policy point of view, we've spoken about whether the blue inhaler should be completely banned, but we can't do it obviously because it's a rescue inhaler for COPD. It's a rescue inhaler for those on triple therapy. So I think maybe if we could think about whether we should have a warning that if you are under 40, maybe this is not your right inhaler, or if you're under 40, ask your doctor whether you should be on this inhaler. So at least a majority of young asthmatics would not be exposed to the blue inhaler, which we're so strongly discouraging. So maybe something like that.
Very good thought. Thanks, Lance. Barnali?
I think we are, those of us who have access to Gina and those of us who follow it are immensely lucky and fortunate because it guides us year after year. But I think the buck shouldn't stop at us, and we should work tirelessly to percolate this information to all doctors so that it kind of helps the asthmatics. And it is not just an individual responsibility of doing good work, but collectively we should rise together to help the asthmatics.
Great, lovely message. Thank you so much. Helen, you have the last word. You have listened to all the expert panelists. I'm sure there are a lot of learnings for you as well. India is a different country as compared to Australia. We have our own challenges, but we have our own opportunities as well. What are your final thoughts?
Well, so what I hear is a lot of expertise and passion about asthma. So you have great expertise in India, but as you know, huge problems in terms of just the sheer numbers of people involved. I think. So I was very interested to hear that burst therapy in emergency departments is something that happens in India as well. I wasn't sure if it was just an Australian thing, but that does highlight that. So look, emergency physicians have to manage many conditions, and we shouldn't expect them to read the guidelines for asthma, for heart disease, for all of the things that might appear in the emergency department. So I think we're conscious that we need to go to emergency department healthcare staff and let them know that there's been a very substantial change in asthma recommendations and what are the implications of that for what they do in the emergency department. Because someone presenting to the emergency department with an asthma exacerbation is an absolutely gold opportunity to turn their life around. You can, prevent the next one, prevent interval symptoms, improve kids' ability to go to school and to play with their friends. So really important to try and embed education about, asthma there's a different approach to asthma now than in the past. So something that's new will often catch attention, and positioning those educational resources in emergency department, in the waiting room, and with the staff can perhaps help. My other take home is, every country is different, but there are similarities in the messages that will reach people in many countries. And so if you've got suggestions about dissemination resources that we could implement from Gina, we would really greatly appreciate hearing about it. We can't do implementation. That's the job of people like yourselves, but learning what messages would work for your populations would be very helpful. So feel free to put those in the, so there's a contact form on the Gina website, or email me and I'll pass it on.
Yeah, thank you so much, Professor Riddle, for those words of wisdom, and been a tremendous learning for all of us. I can tell you that there have been 40 physical centers across India where there have been many doctors who have been listening to this live. In addition to that, there have been many personal logins, a total of around 24 to 2,500 physicians from across the country have listened to this live webinar, where we had the privilege of having the chair of the science committee of Gina talk to us and tell us the latest advances in the diagnosis and management of asthma. Thank you so much, Professor Riddle, for being with us in India, for sharing with us the latest update, and I'm sure that is going to have a huge impact on the quality of care that we would now be able to offer to our patients. This has been an extremely important and memorable webinar. Thank you to all the panelists. I think such brilliant comments coming from everybody. Lance Pinto, Praveen Valsalan, Barnali Bhattacharya, Saurabh Ahuja, and Sushant Meshram. I think you all have been absolutely brilliant in communicating such important messages to our audience. I would also like to express my very sincere thanks to CIPLA for having supported this event. All the hard work that has gone behind the scenes in organizing this event. It's not easy to organize 40 physical centers across the country, where we expect at least around 20 to 40 doctors at one place. So it's been a tremendous evening for all of us, a lot of learnings, and now it's a matter of taking it into a clinical practice to whatever we have learned through what we have learned today is to put it into practice and bring about a change in the lives of our asthmatic patients in India. So thank you very much, and it's been a real honor and a privilege to have moderated this session. Thank you so much.
Thank you. Thank you.
Thank you, Dr. Sabi.
Thank you, everyone.
Thank you for the opportunity.
Very good.
It was so wonderful to see Dr. Helen across and to listen to her.
Yeah,
what a
absolutely.
privilege. What a privilege.
Yes.
Thank you. And thank you, Sandeep, for excellent sharing. That was very
so
helpful.
much.
Thank you, everyone.